Thank you all for watching the video. We will be starting the session in the next 1 minute. Dr. Irene, are we ready to start with the session?
Yes. No, we'll wait till 6:30. I think another 2 minutes to go. Just wait. See, I think we should allow that till that number stops. I mean, it freezes at some level. Just wait for a couple of minutes, ma'am, please.
Okay, meanwhile, Dr. Gary Connet has also joined. Welcome, sir.
Thank you.
Good evening, sir. I'm Dr. Subramanya from Respiratory Chapter. I'm the secretary. Good evening, sir.
Good evening. Nice to see you again.
I think Dr. Subramanya, you can start, then Dr. Chinnappa, and then Eileen.
Dr. Eileen will be the moderator, so I will be starting with the session and we'll hand over to ma'am.
No, 1 second, ma beta. You give it to me, I'll just take over.
Yes, Dr. Subramanya, if you can start the session and then.
Good evening, dear friends. Welcome to Respinars again. These are series of webinars intended by Indian Academy of Pediatrics, National Respiratory Chapter, bringing mouth-watering science to your doorstep, to every pediatrician across the country. And this has been one of the most popular modes of reaching out respirology to every pediatrician. And just for your to recollect for you, the first Respinar was inaugurated by none other than Professor Andrew Bush. We had more than 1,500 participants live, and the subsequently number has remained close to thousands. This is this is a sequence which is being widely popular in spite of many webinars that have been going on parallel by many pediatric subspecialties as well as by Indian Academy of Pediatrics. So thank you very much for patronizing and making this Respinar a successful event as far as the Indian Academy of Pediatrics Respiratory Chapter is concerned. I would acknowledge the presence of our dear President, Dr. Jagdish Chinnappa, who has been a visionary and a man behind all our activities and encouraging us, youngsters like us. While I recollect my dear friend, pulmonologist from my own city, Bangalore, Dr. Eileen Kinimi, who has been also my colleague at the previously organized Respicon at Bangalore. We worked together, we spent a lot of days together. So it was nice, a pleasant pulmonologist, I would say, along with being a really hardworking personality. Eileen Madam, welcome to you. While the main brain behind and a lot of hard work has been put in by Dr. Sneha Varki Madam from Vellore. So welcome to you as well. And our own colleagues from India, Dr. Sushil Kabra sir, Dr. Madhulika Madam, and to add real glamour as well as science, we have got Professor Dr. Gary Connet. Welcome to you, sir. From all our viewers and from the chapter, Dr. Grace Paul sir, and many more faculties who are going to join us. This will be Respinar for 2 days. And I would just share a screen, only one slide, bear with me. So from our IAP respiratory chapter, welcome to you for enriching your knowledge as well as your ability to diagnose and treat cystic fibrosis. So this is a problem that has been uh, of late being well recognized by pediatricians, that it is a general pediatrician's problem as well, apart from pulmonology. So this kind of sensitization is happening, and we are very happy and proud. So Indian Academy of Pediatric Respiratory chapter present to you this Respinar on cystic fibrosis. Are you still thinking you have many more Respinars to come in along with cystic fibrosis? Let me tell you the audience that we are going to have a couple of days later addressed by Professor Annie Chang on cough in children. So that Respinar is going to follow this series on cystic fibrosis. My dear friends, don't wait. I have displayed the WhatsApp number. Please message to me. You become member of Indian Academy of Pediatrics Respiratory chapter and join our family of science. We are always there. You can trouble me at any time, 24/7 at any odd time, and request me how I should become member of the chapter. So with these initial remarks, I will invite today's moderators and chairpersons, Dr. Jagdish Chinappa and Dr. Eileen Kinumi, to take over from us. And welcome to you, and thank you very much.
Thank you, Dr. Subramania, for that wonderful introduction. And on behalf of the Indian Academy of Pediatrics Respiratory chapter, I invite you today for this very, very important Respinar on cystic fibrosis. As you know, cystic fibrosis is a multi-system autosomal recessive disease affecting multiple systems. If you know cystic fibrosis fully, you probably would know the entire pediatrics, because cystic fibrosis affects almost every organ. The awareness of cystic fibrosis was not very much, and I still recollect my closest patient is now 30 years old, gone through a real turbulent childhood and adolescence, and now she's happily married with the CFTR potentiators, and she's doing really well. So it's an honor to listen to the how this disease has been managed in our country. And I can only acknowledge the untiring efforts of Dr. Kabra and Dr. Gary Connett in popularizing the diagnosis and the awareness of cystic fibrosis in our country. We are going to have a fantastic 2 days, and I'm really happy to see that there are many people who are going to contribute to both the diagnosis in the initial part, setting up a registry, and on the second day, how to treat and establish cystic fibrosis. And you will also hear the recent advances on the management of cystic fibrosis. So I will again invite Dr. Eileen, my colleague at Manipal Hospital, Professor Sushil Kabra, who's been the torchbearer for cystic fibrosis in India, Dr. Grace Paul, Dr. Madhalika Kabra, Dr. Sneha Varki, who's been doing extraordinary work in the community popularization of diagnosis of cystic fibrosis, Dr. Gary Connett, who with Dr. Sushil Kabra has set up this way of cystic fibrosis for all practitioners, Dr. Jagdish Goyal, the young Turk from Jaipur, who's Dr. Kabra's student and who is taking forward this in Rajasthan, and Dr. Karen McCoy, who will talk to us about the how it's going to be managed. And of course, we are all going to learn. Dr. Subramania and me will learn about many things that of cystic fibrosis in the next 2 days. So thank you very much for all of you to being here. I'm not going to go through the program because I'm sure all of you have seen this. So with these a few words, I hand it over to Dr. Eileen to take it forward and moderate the first day's proceedings. Thank you very much.
Thank you very much, sir. And we'd like to begin today's program with an overview of cystic fibrosis. We have none other than Professor S.K. Kabra, and it gives me a great privilege and an honor because sir has been our mentor, our guide, a huge driving force. He currently heads the Division of Pediatric Pulmonology at All India Institute of AIIMS, Delhi. He has been at the forefront of research and patient care in the field of pediatric pulmonology. He is renowned world over for his pioneering work in cystic fibrosis, tuberculosis, and many other aspects of pediatric pulmonology. Over to you, sir.
Good evening, friends. Thank you, Eileen. And I am very thankful to Dr. Jagdish and Dr. Subramanya with the help from Dr. Sneha for giving us a great opportunity to learn more about cystic fibrosis. And we will be learning from Gary, Grace, and Karen, along with our friends from India. Okay, so outline of my presentation is that I'll be talking to you in next 20 minutes, all these things. So as Dr. Jagdish said, it is a multi-system disorder. It starts from chronic sinusitis, nasal polyp, lungs, GI symptoms, sexual organs, as well as significant psychological stress on child and family. And there is an economic burden on family, and there are high expectations. Once we make a diagnosis, then the parents, they have a very high expectations from us. So cystic fibrosis is a disease which was considered to be a disease of Caucasian, and there was a myth that it doesn't happen in other ethnic background. But if you see, this is a recent data under publication in Pediatric Respirology and Critical Care Medicine, a journal of APPS. You see here, we sent our questionnaire to 20 odd members, and you can see that almost all of them except 2 or 3 in Myanmar, Vietnam, and Macau, all of them are having some cases of cystic fibrosis. And you can see another important thing is that the mutations are there, but they are different. They are very variable, and their profile is different from that seen in Caucasian population. So over last 7 decades, there is significant research has undergone the cystic fibrosis, diagnosis from just sweat test to nasal potential difference and clinical exome sequencing. And there is an improvement, significant improvement in the management, specifically physiotherapy. Now a lot of devices are being used. Earlier, it used to be just children were being kept in the tents to keep their secretions thin. But now it is DNase and hypertonic saline, systemic inhaled antibiotics, potentiators, and gene therapy. And you can see that in the 1950s, the median survival was 6 months. Even in the developed countries, it has increased to 5 decades. However, there are certain challenges in the lower middle income countries. In a recent review describing status of CF diagnosis and care in different 4 countries like Brazil, South Africa, Israel, and our country, India, and it is describing that still associated with death of infants and young children due to cystic fibrosis. There are significant challenges, non-availability of diagnostic tests, and care due to financial constraints and significant burden of other diseases. Newborn screening may not be feasible for countries with lower income and high birth rate, such as India and South Africa. And CF therapies and care in LMICs need to be adopted to available resources. It is very important that we should learn that we have to adopt. We cannot take the ready-made CF protocol from America, European countries, UK, but we have to see what are our resources. So it is very important. Another thing is there is a collaborative initiative, as I'll be showing you that how we learned CF. So it is very important that we learn about CF from those who already have a lot of knowledge about CF. So there is a need for global CF community with LMCI to work together. And most individuals with CF are not benefited from CFTR modulators in our countries. So what happens? Because of rapid research, advances in management, information are available all over the world within few days of research. However, there is a discordance between the information technology, which is very fast, and development index of the different countries, which is not very fast. Interaction between the patient in different subgroups by WhatsApp and other social media. So knowledge of advances but interventions are not accessible to majority of people in our country that I'll be showing in my few slides. So it is leading to frustration in the physicians, patients, and parents. Let us see what about CF in India. First case was reported in 1968 from PGI Chandigarh, and when I searched from 1968 till 2020, there were around 456 articles. But you can see here in 1970, before 1970, it was only 5. 71 to 80, whole decade had only 2 articles in PubMed. In 81 to 90, there were 5. From 91 to 2000, it was 22. And in the last decade, it was 100. And in this decade, you can see there is a sudden jump of the articles being published from India or children with cystic fibrosis. So now I just tell you about the last 3 decades of CF at AIMS. So in 1994, we were suspecting from 92 onwards cystic fibrosis. We collected some samples, but we were not very sure about their diagnosis. So Dr. Verma, IC Verma, he was the genetics head at that time in our AIMS, and he brought a kit to document Delta 508, to test Delta 508. And Madhulika, she is my wife, better half, and you will be hearing her. She and her team tested for Delta 508, and 2 were homozygous and 2 were heterozygous. And this gave us a confidence that these are the children with CF and it exists in India. Madhulika tested 24 more samples at St. Mary, Manchester in 1996 as a British Pediatric Association's fellow. And at that time, when we got a positive reinforcement, then we decided to work on developing a sweat test. And we developed in 1995-96 indigenously developed sweat test. And within 7-8 years, we had 120 children with CF. You can see this was published in 2003. This is the place of origin, that patients were coming from all over origin, or residents all over the country. Because of referral nature, we are getting patients from all over the country. Even if we say the place of origin, you can see they are all over the country. So it is not the disease of particular region, particular ethnic group, but it is happening in all over the country. So if you see the estimates of CF, if we say that we are 1.3 billion, 20 per thousand per year is the birth rate, then if we say that it is 1 in 2,500, which is the estimated, which is the frequency in Caucasian population, in our country, we may be having 10,400 newborns born with CF every year. If it is 1 in 10,000, 2,600 per year. And if it is 1 in 40,000, then 650. All of them are not diagnosed and get improper treatment. So if we say what is the probability of a pediatrician coming across CF patient, if we say there are 600 districts, each district has a 50 because our pediatricians count is 30,000, and CF patients survive for 5 years. Each patient may have a 6 episode of respiratory problem per year. Then if it is 1 in 2,500, a pediatrician may be seeing around 10 children per year with lower respiratory tract infection without diagnosis of CF. If it is 1 in 10,000, 2 to 3 children are being seen per pediatrician. And even if it is 1 in 40,000, it may be 1 child, which is not diagnosed, but it is being treated as pneumonia. So our clinical manifestations different in Indian children. So over last 3 decades, we accumulated our experience and published them. So one is that the children may present with hypokalemia, hyponatremia, alkalosis, metabolic alkalosis with pseudo-Bartter syndrome. Then they have a more frequency of meconium IS equivalent. They are colonized, significant number, almost half of them are colonized with the pseudomonas by the time it is diagnosed, and that is the reason for severe disease. Even we see children with vitamin A and vitamin D deficiency, fat-soluble vitamin, which is almost non-existent in the Western world, where there is the children are diagnosed by the perinatal, by the neonatal screening program. But in our country, still delayed diagnosis is responsible for these symptoms. And our mean CF score suggests that our disease is more advanced at the time of diagnosis. There is a seasonal variation in growth because of the fluid and electrolyte problem. Almost all children are having a low bone mineral density. They have almost 18% of children about 10 years of age may develop a allergic bronchopulmonary aspergillosis. They have even iron deficiency. Zinc deficiency is okay, but even iron deficiency, which is not considered to be a problem in children with CF in a developed CF unit. CFRD is present after 10 years of age, almost cystic fibrosis related diabetes in 21%. And recently we observed that almost 67% of our children about 10 years of age are going into a depression. So it is very important and these are unique to us. Then other thing is almost half of our patients may have a peripheral neuropathy, and malnutrition is a significant problem. There is a significant correlation with the time to diagnosis and from onset of illness, suggesting that by the time we make a diagnosis, they are malnourished. And the other thing is, if we see pulmonary exacerbations during the second year and third year had a significant correlation with the weight for age G score at the beginning of the respective years. So it suggests that malnutrition plays a significant role, which remains a neglected part as far as our management is concerned. Similarly, our group has generated data regarding what are the microbial agents which are responsible for pulmonary exacerbation. You can see Pseudomonas, Burkhardellia, Staphylococcus, which is now again emerging in a big way in our patients. Similarly, viral pathogens are significantly associated with exacerbation, and we have observed this and reported that once there is a viral infection, specifically with influenza, there is a significant increase in the morbidity and mortality due to respiratory illnesses. Fungal pathogens, specifically Aspergillus and Candida, are increasing, but we could not document any mycobacterium species which has been emerging from other countries, specifically from UK. So what are the challenges and solutions? Ignorance of physician, how to confirm diagnosis and how to manage. So ignorance of physician about CF, there is a need to create awareness by the workshop. And our group has created this 120 slides, which is an interactive session of almost 2 to 3 hours. In a group of 30 pediatricians per workshop, we try to encourage them to attend and then think of CF. Similarly, if they make a diagnosis, if they suspect a diagnosis, we need to provide diagnostic and management services for them. Similarly, now, how to make a diagnosis? Once I have created, then how to make a diagnosis? Clinical features with sweat test, 2 mutations, or transnasal potential difference. But sweat chloride remains the gold standard. And our problem is, in 1999, there were 4 sites which were providing services for a sweat chloride. And in 2018, 9 centers are providing. So it is still not available widely. And to take care of it, as I told you, in 95, 96, we developed a indigenous sweat chloride testing equipment, which cost around 500 rupees, which is equivalent to that of a $10 US, and per course test is less than 25 rupees. This was in the beginning, 95, 96, and this is Madhulika, on which they are testing the equipment. This is another one, which is again tested on Madhulika, and now it is looking like this. It is much lesser expensive as compared to the macroduct sweat collecting system. Some centers are having it. The major issue is, though initial cost is around 15 lakh, but major issue is per test cost is around 5,000 rupees, which is not affordable for time as of now. So one of our patients sent a hand photograph of a patient that when she gives the bath, mother thought that when she gives the bath, there is a wrinkling of the skin. So we thought that it may be worthwhile seeing it. And when we checked the literature in 1973, in Lancet, there was a case report that if you dip the child's hand who is suffering from cystic fibrosis, he'll have a rapid wrinkling. So our group tested it, and we could find that if within 3 minutes child develops a wrinkling, then sensitivity is 81%, though specificity is less. And this is the small video suggesting how you can perform. If you are suspecting it to be CF, just check the hand of the child, compare it with the other hand, one hand is put in the water, which is a lukewarm or room temperature. After 3 minutes, see whether the child has developed a wrinkling, and compare it with the other hand. And it is a very sensitive method, though less specific. But still, sweat testing is not available. What we suggest is consider CF if a child is having a failure to thrive, recurrent persistent pneumonia, large foul-smelling bulky stools. Investigate for hypochloremia, hypokalemia, hyponatremia, metabolic alkalosis, head globules in stool. And then if 2 of these are present, then you may consider that it may be a CF. But confirm the diagnosis only after doing a sweat chloride O2 mutation analysis. So now the second thing is, now this is something which we feel that may be useful for making an early diagnosis. There are very few centers which provide a CF care, very few trained manpower, medications are available but very expensive, and physiotherapy is hardly anything. So there is a need for learning it. And how we improved our knowledge of CF. We had a twinning with Southampton CF unit. You can see Gary here. And here, this is a photograph in probably 1999, and this is in 2005. And they helped us in learning this. I had not seen even a single case of diagnosed CF during my post-graduation or during my pediatric training. And they train our physiotherapists also, which we are now training other people. So now the thing is that if we provide clean environment, dietary advice, physiotherapy, and regular, this doesn't cost anything. But if we do a basic radiology, vitamin, salt supplement, bronchodilator, and hypertonic saline, it will cost us around 2,000 per month. And if we do a pancreatic enzyme supplement, microbiology culture, it will cost us around 5,000 per month. And if we say I inhaled antibiotic, then 20,000 per month. And if we do give DNAs, then 95,000 per month. And if we use potentiators, then it may cost us around 10 lakh per month. And if we use Dike-alpha, then it will cost us around 50 lakh rupees per month, which is very expensive. And if you can see, if you provide these things, then there is a rapid increase in the benefit. But if you do this thing, then it gets plateaued, and whatever you give, there is a decrease in the benefit. So it is important to understand that at least we can give these following things, whatever our patient can afford. So I'll show you our experience of Orkambi. This is a 19-year-old girl, and then we started her on Orkambi here, and you can see that there is some improvement in her FEV1 as well as CF score, but it is at a cost. So where should we put our efforts? One is, this is the data from our institute, that if you see a patient outcome, then nutrition at the time of diagnosis creates a trouble. And if those who are malnourished, there is less chances of survival. Those who are having a frequent LRTI, chances of survival are less. Those who are having this thing, Pseudomonas at time of diagnosis, the chances of survival are less. So that's why what we can do is, we can make an early diagnosis. If we understand that CF does occur in India, need to develop a diagnostic test. Sweat test remains the gold standard. Aquagenic wrinkling has a potential to be used as a screening test. Early diagnosis and taking care of nutrition with regular follow-up. It is very good intervention. Follow country-specific management protocol, which is very important, as I told you in the beginning. And this is which we developed country-specific, in which some people work together, and then we decided that yes, this is a treatment protocol which is suitable for our country. And as survival is improving, need to develop care of adolescents. So what is the way forward? Expand cystic fibrosis registry, which you will be hearing from our colleagues. Promote self-help group to purchase medicines directly from company and distribute among their members. Get some exemptions from government. Fundraising to help those who cannot afford, and research to develop suitable protocols. So you can see these are children with cystic fibrosis. Incidentally, these four were together in the clinic, and you can see that they are more than 20 years, and almost 20% of our population is more than 20 years, and they are bigger, taller than me. And this is our CF services. And you can see here that we are concentrating more on monitoring, anthropometry, spirometry, taking their cup swabs, and that is improving our survival. And we have to go a long way to take care of these, to improve the care. As on each visit, they will be seen and they will be checked for the physiotherapy. So we need to train our physiotherapists in various ways. We have to use our own methods rather than taking ready-made protocol from West. So this is the these are the CF patients. We have to still long way to go to achieve outcomes similar to CF units in developed countries. But early diagnosis, chest physiotherapy, and judicious use of antibiotic and nutritional management can improve the quality of life and survival in CF patients in developing in our country. Thank you very much. Thank you. Now I'll stop sharing, and then Eileen can take care of the next presentation.
Thank you very much, sir, for your very enlightening talk, and also a constant reminder for all of us that we still have a lot to go, and for Dr. Kabra for his excellent contributions in leading the journey for each one of us here. I'd like to welcome our next speaker, Dr. Grace. Welcome to this meeting, Dr. Grace Paul. Dr. Grace is a pediatric pulmonologist with special interest in neuromuscular and sleep disorders at the Nationwide Children's Hospital in Ohio. She is also the principal investigator for the CF India project, supported by the CF Foundation USA, and currently collaborating with Dr. Sneha's team at CMC Vellore. I'd like to hand over this time to you to enlighten us with the next talk about diagnosing CF early and your experiences there. Over to you, ma'am.
Madam, please unmute yourself.
Okay. Are you able to see me and hear me now?
Okay.
Yes, we can see you.
Okay. So thank you once again for this opportunity. I thank the members of the Indian Academy of Pediatrics for inviting me. It is an absolute honor to give back to India, and that's where I'm from. And I studied at CMC Vellore and have worked with Eileen and Sneha in the past. So thank you, Dr. Kabra, for your excellent work. We have so much to learn from you. And so I'm going to be presenting about the current state of newborn screening in the US, and talking a little bit about the progress over the past 30 to 40 years and how early diagnosis has made a difference. The thing is, because I'm from India, I'm very passionate about CF care in India. So even though I'm going to be presenting somewhat of the ideal situation, this is something that I envision for India sometime in the near future. So, okay. So the first, the bottom line of my talk is that early diagnosis of CF does improve clinical outcomes. And briefly about where I'm from. Right now I'm in Columbus, Ohio, and this is my hospital, Nationwide Children's Hospital, affiliated with the Ohio State University.
Can you share your screen? Can you share your screen?
Madam, you have not shared the screen.
Oh, okay, sorry. I thought I was.
Yeah, fine.
Can you see now?
Yeah,
okay.
We can see now.
Slideshow.
Slideshow, madam.
Yeah. Now?
Yeah, fine.
Okay. So this is Nationwide Children's Hospital, currently ranked 8th best children's hospital in the US and 6th best pulmonary department. And this is the whole hospital in relation to downtown Columbus. So the outline is, I'm going to just briefly mention, early diagnosis includes predominantly clinical diagnosis, some bit of antenatal diagnosis, and in the US we focus a lot on newborn screening. And I will also talk a little bit about our hospital's data. So, clinical diagnosis, we all are aware and are thinking from what Dr. Kabra has presented and from working with Dr. Sneha is that, even without a diagnosis, if we have clinical symptoms, we need to start treatment. So that's the bottom line of our, what we work with, what is available at this time. So we have excellent clinicians in India, and, just putting together a couple of symptoms can promote diagnosis. The negative of this is that, to get that classic phenotype, it takes a couple of years to build up. So by the time the child comes to us, they're already in a very severe state. So there is very high morbidity and mortality. Antenatal diagnosis, currently the American College of Obstetrics and Gynecology and Genetics have recommended some prenatal screening. And then if the mother screens positive, then the father gets tested. And then there is options for prenatal diagnosis, or families generally tend to wait for newborn screening. Currently, newborn screening across the world, you can see all these places marked in orange where newborn screen is currently active. And then you can see many other countries in Southeast Asia, Africa, and part of Central America are also in the works. The main thing that we are testing with newborn screening is the enzyme called immunoreactive trypsinogen. And we started diagnosing using this since 1979. And what we are doing is collecting a sample of blood as soon as the baby is born. And we on a card, special card called the Guthrie card. And you can see since the time of newborn screening, the number of diagnoses has increased tremendously. So what is this enzyme? So normally the pancreas produces an enzyme called trypsinogen, which gets activated to trypsin, which helps in protein breakdown. When there is any problem with the pancreatic duct, the previous step, that number is increased, and that's what happens when our IRT goes up. So this is sensitive, but it's not at all specific. So that's why we need secondary testing. It can be high in perinatal distress, prematurity, and in the US among African American population. And interestingly, it can be low in meconium ileus, and therefore, even though our classic CF patients have meconium ileus, they may be missed on an IRT. The reason we need further testing is to reduce false positive and improve our second sensitivity and specificity. And then important thing is the IRT values are very high at birth, and then they reduce by 3 to 4 weeks of age. In the US, it first began in 1982 in Colorado, and then the CFF, the Cystic Fibrosis Foundation, and the CDC have had some meetings together where they have reiterated the importance of doing this. And then the main focus is on the consequences of delayed diagnosis, and then in terms of pulmonary, cognition, and also the cost effectiveness. So currently, newborn screen is available in all the 50 states of the US. What's the rationale for doing it? It's basically identifying patients in their pre-symptomatic stage so that you can make a difference. In talking to Dr. Sneha, there's been multiple cases where even like at 3 months of age, when the infant presents, there's a lot of morbidity already. So our goal is to diagnose them even early to prevent early morbidity, early death. So briefly describing some of the clinical benefits of newborn screen, and this is data from Canada and also from the US. So you can see that they had about 200 kids who had newborn screening and 200 kids who did not. And this was about a few years ago, but you can see the big difference in height, in weight, and also in BMI. You can see the change among those who had the screening versus not. Similarly, here what we are looking at is the amount of children, the weight for height. Again, those who were screened versus not screened. This is from a US paper. And you can see significant p-values. And then this one is saying number of kids below the 10th percentile. So that's like severe malnutrition. That's what we consider. And the number of children malnourished, severely malnourished, is much lower among the early diagnosis kids compared to the late diagnosis. Similarly, the occurrence of Pseudomonas and staph infections. So earlier occurrence of Pseudomonas and the first occurrence among those who are screened later, and staph. And then this is also the cumulative percentage of infections among different the children compared to those who were diagnosed by newborn screening. Another way they looked at this was healthcare utilization, how many hospital days, the number of hospitalizations. So the clinical diagnosis group was much worse than those diagnosed by newborn screening. Survival, this is showing a birth cohort. So you can see different decades or like 5-year gaps. And you can see that here they have mentioned, so between the babies born between 86 and 90, survival was up to age 15 was 93%, and then it's been gradually increasing. And right now we are at this line or even higher, where our survival rate is much higher. And then this graph from Europe actually shows that if a person has mild to versus moderate to severe CF, what is the trajectory if they were diagnosed through newborn screen versus symptomatic diagnosis. And you can see the, those with clinical diagnosis had a significantly lower survival curve than those by newborn screen. The other advantage is, even though the initial cost may be higher, the overall cost is lower. There's good cognitive achievements, lesser stress in terms of earlier diagnosis. We know what to do. We can just follow the protocols and the CF care team. It also helps with genetic counseling and testing of siblings. But so now we know that it's really beneficial, but then why aren't we doing it everywhere? So the main thing is, we can collect the sample, but then what's next after that? So we have to have a perfect infrastructure. So once we have a sample, where does it go? Where is the diagnosis confirmed in terms of a sweat test? And who communicates? Who initiates the care? So there is a big chain or steps to be followed to make the newborn screening ideal and successful. So the suggested criteria right now, where it would be the most effective is incidence is pretty high. The test has to be quite sensitive. The IRT DNA method is a little bit more better. They should have access to sweat chloride test within 4 weeks, because the whole thing of newborn screening is early diagnosis, early management, and a good team to help them. There are different algorithms for newborn screen. And you can see one is called the IRT. So basically we do a IRT level one day and then repeat it 2 weeks later. Or what is more commonly done right now in the US at least is IRT DNA. If the IRT level is above a certain level, they automatically get a DNA testing. You can do only for one gene, which is the most common here, or you can do for multiple genes. So there are different protocols for each of these. So you can choose either an absolute IRT value, or you choose something called a daily. Suppose 100 kids are tested, what's the highest percentile? And then we pick that value and we classify children. And this percentage method helps avoid the problem of seasonal variations, delay in transfer, but there are some negatives to that also. The IRT is sensitive. We need to repeat. The advantage of this is, as I mentioned, the IRT value does drop after 2 to 4 weeks. So in that way, we can actually screen better and increase our positive predictive value. And then also by doing this, we avoid unnecessary DNA testing for every carrier person. One, it's expensive, then it causes a lot of problems. The main problem with this test is the baby has to come back in 2 weeks' time to get it tested. The DNA advantage is it's a single sample. And then I mentioned you can do different types of testing for DNA mutation. But important is to know what is the most common mutation. For example, in the US, F delta 508 is the most common, but I know in India we are seeing only like 20 to 30%. So is F delta the gene to go after? The decision to decide what we are choosing, like which algorithm, depends on multiple reasons. And whether it's scientific, what's the clinical utility, is it practical? And then also, what is the availability of other reagents, what's the CF genotype variation, things like that. This is within the US itself. You can see different states are here, and they each use different cutoff values or different percentage values. So it is a very state-specific testing that we are doing here. So these are just a couple of algorithms that are given. So if a patient is CF screen positive and have 2 mutations, everybody gets a sweat test, and then you can either make them a diagnosis of CF if they are symptomatic, or something called CF-related metabolic syndrome if they are not symptomatic. And then this is a very busy slide, but then it just gives the current algorithm for if the IRT is high and with one mutation. So again, same thing, you go by whether they are symptomatic and what's the sweat test level. These are the new terms that we have now. What is CF, we know, and then what is CF related metabolic syndrome, also called the CF, screen positive inconclusive diagnosis, or a CF related disorder where there is a symptom in only one system, medical system. Sweat chloride is the standard, gold standard, and then anything above 60 is diagnostic. If less than 29, they are normal unless they have two mutations also. And then again, if they are in the intermediate zone, we have some good algorithms on what we can do to confirm whether they are CF or they are the CRMS or normal. The other alternate diagnosis which we use for early diagnosis can be nasal potential difference. Sometimes we get patients who get GI testing or pancreatic or biliary panel, and then they get referred to us as infants, so we can help initiate treatment even then. So now that we have made a diagnosis through newborn screening confirmed with sweat, what do we do? And I just want to share some examples from what we do at Nationwide Hospital. The CFF or the Cystic Fibrosis Foundation has given very detailed, you can see like when they come, 1 week later, 2 months, every month what we can do. But again, this has to be sort of tuned, personalized to each patient, but also sort of, we have to use it according to the resources that are available. So in our first meeting, there is a lot of stress. We still focus on, after we reassure the family, we focus on nutrition, enzymes, salt, and multivitamins, teach them some hand CPT, and we initially follow them every 2 weeks. And in the first year of life, we are gradually introduce medications, even start Dornase alpha in 6 months. Every 2 months, the baby comes and we are able to get throat cultures, we get a chest x-ray, and at our institution, we have the ability to do infant pulmonary function tests, and also we do annual chest CT with lung volumes. So this is an example of one of our patients getting infant PFTs. So what we are able to pick up, and as you can see, is we monitor this FEV1 0.5, FEV 0.5 to FVC, and you can see that the ratio is small, indicative of early obstruction, and these babies do get treated. And also the curve is a little bit slow, scooped. And inhalation and exhalation films, we pick up early bronchiectasis and we're able to treat them. I just did a small, gathered some data on babies born in 2018 and their nutritional outcomes. They are followed very closely by our dietary team. So you can see among the girls, what's the percentile of weight, and among the boys, the percentile of weight over the first 2 years of life. And then, so I'll just end with the ideal diagnosis and management course. This is a boy who's now 13 years old, and he was diagnosed through the newborn screen. So what you can see is the IRT level was 502. So normal for that day was less than 140. And even in that, they were able to diagnose that he was homozygous Delta F508. And then immediately the hospital is informed. Within 2 weeks, he gets a sweat chloride, and then he also gets a pancreatic elastase. And over the years, he has generally had a very good course. This is FEV1 100 here, and he has done really very well. And, based on symptoms we have, this is around 2 to 3 years of age when he started Dornase alpha 7% hypertonic saline. He's had only like a couple of exacerbations. And then we have done like azithromycin, and currently, this arrow should be here, started on Trikafta. This is his CT scan from now, 13 years, and this is his recent bronchoscopy that was done for a surveillance. His bacteria, his growth chart has been pretty good. He's been very compliant, participating in, doing very well in school, sports, participating in CF research, and very good family situation. So this is what would be ideal for all our patients who would be diagnosed. This is not perfect for all our patients here also. The last one is early diagnosis is now also enabling patients to get onto CFTR modulators. So right now the ivacaftor for G551D is approved for 6 months of age. So but these babies will never know what CF meant. Orkambi, Symdeko, and Trikafta are all newer drugs. So Orkambi for 2 years onwards, Symdeko 6 years onwards, and Trikafta right now for 12 years, but soon it's going to be approved for 6 years. So conclusion, early diagnosis does improve clinical outcomes. IRT DNA would be ideal. For India, we need to figure out which would be the mutation and is it cost effective to do it. A strong infrastructure is needed. And then sweat test is the gold standard. And then there are newer phenotypes, and we have to decide where our patients fall in, because I know some of our patients' mutations are not even recorded in CFTR2 website. So I want to thank everybody for this opportunity once again, and I'm happy to take any questions at this time.
Thank you. Thank you, Dr. Grace, for that wonderful talk. And we do have a few questions, but we had actually planned to take all the questions towards the end of the, towards the end of all the sessions. So I hope the questions can be typed in by the attendees, and all can also have a look at the questions that are being typed in. We'll move on to the next talk, and essentially this is regarding CF genetics as well as antenatal diagnosis. We'd like to welcome Professor Madhulika Kabra. She requires no further introduction. She's also been introduced as the better half of Professor Kabra, but ma'am is a professor, and she heads the Division of Genetics, Department of Pediatrics at All India Institute of Medical Sciences, Delhi. She also is heading the WHO Collaborating Center for Clinical and Lab Genetics. She's been in this medical genetics and has extensive experience over the last more than 25 years. And I'd like to give her this time to take over.
Dr. Madhulika, madam.
Okay, are you able to see my slides now?
Madam.
Are you able to see my slides now?
Yes, madam. Yes, yes.
Yes, yes.
Okay,
yes.
okay. Good evening, everybody. Thank you very much for this kind introduction. At the outset, I would like to thank the organizers from the Respiratory Chapter of Indian Academy of Pediatrics for inviting me to discuss with you about the genetics of cystic fibrosis and antenatal diagnosis. The plan for the presentation is going to be, I'll be talking a little bit about the cystic fibrosis gene, the mutations and the type of mutations, the importance of molecular testing, not only for diagnosis, but why else it is important. What is the mutation spectrum in India and the implications in molecular testing, the mutation testing strategies which probably can be followed in India, and a little bit about the genotype-phenotype correlation and the modifiers of the phenotype which have come up now, and counseling and prenatal testing. Now, cystic fibrosis, you all know, is one of the most common life-threatening genetically inherited condition affecting the Caucasians. You have already heard about the carrier frequency of 1 in 25, which translates into about 1 in 2,500 live births in Caucasian population. It's a multi-system disorder. You also heard that it has an autosomal recessive inheritance and was thought to be uncommon in people from Asia. But you all heard that many cases are being identified in India, and you can even imagine this fact because more than 250 people have joined this particular webinar for this very, very targeted disease. So I think interest in cystic fibrosis is definitely increasing. The scenario in India, which is emerging based on some of the molecular data which has recently come up, is quite interesting, and we'll be talking about it as well. So autosomal recessive inheritance, you all understand, both partners being carriers. The risk of recurrence in each pregnancy is 25%, and the 75% of the babies are going to be normal or carrier. So 50% chance of being a carrier and 25% chance of being 25% chance of being absolutely normal. And whenever we are counseling the family about this, it is important to tell them that this chance does not have any memory, because many of our patients do not understand this, that each pregnancy has a risk of an affected child of 25%. So the CFTR gene was sequenced in 1989, and till now more than 2,000 cystic fibrosis mutations have been reported. So you can imagine the heterogeneity of the mutations which has been identified in the CFTR gene, and the mutations affect the function of the CFTR gene in different ways. So this is the CFTR gene on chromosome 7 on the long arm, and this is showing the structure of the CFTR gene. You see it's a long gene, it's a big gene with 27 exons with 1480 amino acid protein having different domains, and the mutations are scattered all over the gene. If you see the worldwide information about the mutations, though you heard, and in the Caucasian population, I mean, it is fortunate that we have one common mutation and testing is easier. Now, these are the types of cystic fibrosis mutations which have been reported, and you can see here from class 1 to class 6 which have been reported, and the severity of the mutations when you go from class 1 to class 6 actually decreases. So you can see that in class 1 and class 2 there is actually no protein. So these are severe mutations, and as you go further, even class 3 has no function because it's a functional defect, and the rest of the 3 classes of mutations have milder manifestations because there's less function, there's less protein, which may be less stable, but some CFTR function remains. So why do we need molecular studies in patients with cystic fibrosis? So one is confirmation of diagnosis. So if you have 2 pathogenic variants identified in the CFTR gene and the phenotype is consistent, there is no doubt about the diagnosis. You may have cases with borderline sweat test and the phenotype is quite suggestive. In that case also, mutation testing is very useful. You all know that some of the cystic fibrosis mutations have a normal sweat test, which is one of the relatively common mutations seen in Indian population, which is in intron 19. And in these patients, if they are homozygous for this particular mutation, they have normal sweat values. And in certain situations, sweat testing may not be possible. A very sick child who cannot be transported. As Sushil said, that there are very few places where sweat testing is being done. But if you have a very high clinical suspicion, at times in newborns, it becomes difficult to do a sweat testing, and absolutely valuable in prenatal diagnosis. So if you want to offer prenatal testing in the next pregnancy, you have to have mutation reports in hand. And as I said, there is some genotype-phenotype correlation, so you may prognosticate the patients as well. And as you heard, targeted therapies are there based on the mutation profile, and you will be having a talk on this tomorrow in details. So the mutation testing methods can be targeted methods depending on the profile of mutations that particular population has, and you can have simple methods which are PCR based. You can have direct sequencing of the whole CFTR gene, which is the gold standard being Sanger sequencing, but it is time consuming and it is expensive. You can have targeted panel of mutations which are population specific, but it is only possible in situations where you have a good number of mutations which cause CF in that particular population. If it is highly heterogeneous, you cannot have a targeted panel. You can have whole gene sequencing, which is NGS based, next generation sequencing based techniques, which is rapid, and you have the cost is also less as compared to Sanger sequencing. A very small proportion of cases of CF, they may have deletions or duplications in the CFTR gene, and for that MLPA may be required, and this is less than 1 to 2%. And if the diagnosis is not certain, you have some overlapping phenotypes, in that situation you can undergo exome sequencing, in which theoretically you are sequencing the disease causing genes which are which are the genes, the exome regions of the genes, which are actually expressing and making which are actually translating. So this is just a cartoon to show you the exome sequencing. And in exome sequencing, you actually sequence all the exonic region of the whole genome, and then theoretically covering all 20,000 genes which are known till now. So if you have a doubt in the phenotype, then it may be better after testing for common mutations, you may go in for exome sequencing rather than doing CFTR sequencing alone. Now, the mutation spectrum in the European population has already been alluded to by Grace. So 75 to 80% of patients with CF have delta F508 mutation, and there are other 5 to 10 relatively frequent mutations. So in such populations, you can have some panels, but it may not be useful in population like ours, as we'll see further, as we are highly heterogeneous genetically. And the remaining mutations in all the populations are highly private. You will hardly find a second family if you identify one specific mutation in that particular population. So in India, as Sushil was alluding to, we started working in this area in late 90s, early 2000s, and then this just trying to find out the carrier frequency for delta F508. This work was done with one of my MD student, Dr. Vishal, and delta F508 was tested in about 1,000 cord blood samples, and which gave us a carrier frequency of about 1 in 250. So this was only delta F508 testing, and obviously all mutations were not tested. So based on this, the CF was identified to be quite rare, but it actually exists. That's what we came to know, and we are just getting more and more cases now. Now, this is one interesting article which is under publication, and this is from Dr. I.C. Verma's group in Sir Gangaram Hospital in collaboration with MedGenome, where they screened 200 unrelated participants who were not at high risk for having a genetic disorder and screened for some of the relatively common disorders. So the most frequent carrier status was identified for congenital deafness, and you will be surprised to see that cystic fibrosis was the second most commonly observed disorder with a carrier frequency of 1 in 22, which is almost like a carrier frequency of beta thalassemia in our country. So it looks like that CF is much more commoner in our country as compared to what we think. So studies with very large sample size are required to find out the actual carrier frequency, and for this actually you will need to have NGS based testing, which is going to be very expensive. So this is the data which was provided in this paper, and this population was from North India, and you will be surprised to see that only one individual had delta F508 mutation, the others were different mutations. So we may be having other mutations which are there, and delta F508 though still is the commonest mutation. So if we look at the genotype of Indian children, there is sufficient data now available from various centers in the country, which suggests that about 20 to 30% of the patients have delta F508. So there is no doubt that this mutation has to be tested first, and which is widely available in the country now and is not very expensive to test. Now, this is thesis work of by one of my PhD students, Dr. Shivaram, and he, when he worked on cystic fibrosis, at that time he tested 100 patients of cystic fibrosis, and we used a screening technique called SSCP after testing for 2 common mutations. And the conclusion here was, and which was followed by sequencing, if we found a change in SSCP, then the about 50% of patients remain uncharacterized here, and this was because of probably patient selection and also because of the technique which we used for mutation testing. But what you can see here is that after delta F508, these are the patients who were positive for the mutation, 33% delta F508 and other very heterogeneous. The second next common was the intron 19 mutation, which we identified in a significant proportion of patients. Now this is just to show you the polyacrylamide gel electrophoresis, which is being used for delta F508, a 3 base pair deletion, which can be very easily tested. You can directly go in for sequencing by Sanger if you know the mutation, or if there are some common mutations which are known in your country. Now this was another project which was completed about 2 years back, and this was from the AIMS intramural grant, and here the criteria for selection were more stringent, and after testing for 2 common mutations, rather than going for screening techniques, we did the CFTR sequencing using NGS. So the sample size here was small, but what we found was that delta F508 was in homozygous state was in 44%, in compound heterozygous 10%, intron 19, homozygous 4%, and compound heterozygous 6%. So the results are more or less same. And then you can see very important thing here, the other spectrum was highly heterogeneous. Mutations were identified in all patients except 2. In one, we were not able to identify any, but in another, only one mutation, delta 508, was identified. So then this shows that if you have a stringent criteria and the inclusion criteria for mutation testing is good, in that situation, we will have good results and the yield would be more. So based on this, the strategy which can be followed for CFTR mutation testing, first of course is delta 508. This is a new nomenclature for delta 508. And then after that, is heterozygous or negative, then you can have, we had 2-3 more mutations which were commoner, but what usually we do is we go in for the intron 19 mutation, and following that we would be sequencing the whole CFTR gene. And as I said, MLPA can be done in a small percentage of cases which are negative. As I said, the deletion duplications are very low. Now, just touching on the newborn screening issue, which Grace dealt very nicely just before me, if at all India considers newborn screening for cystic fibrosis, the confirmation is going to be a problem unless we have very good facilities for sweat testing. And if we want to go the IRT DNA way, in that situation, we do not have a second common mutation, maybe the intron 19 one after delta 508. So if you want to confirm it by a genetic test, then it has to be the whole CFTR gene sequencing after testing for few common mutations. So this will be one problem which we need to deal with in case maybe later we have newborn screening in place for CF. Now coming on to the genotype-phenotype correlation, the type of mutations affect the severity. I've already said there can be some polymorphic variants in the cystic fibrosis gene, which we call as polythymidine sequences. And depending on the number of poly-T alleles you have, the severity would change. The lowest one would have less severity, like 5T. There are other modifier genes and there are environmental influences also which modify the phenotype. So this picture just shows you that how the CFTR protein function is related to the sweat chloride. And you can see here that if the sweat chloride is in the lower range, as Grace was just explaining, these all are normal, same is for carrier, but in the borderline range, you can have some milder phenotype, and in the clear-cut range, you will have severe phenotype with pancreatic sufficiency or insufficiency, depending on the type of mutations you have. Interestingly, apart from the genotypes, there are multiple modifiers which may modify the phenotype of CF individuals. And here you can see that apart from the genotype, which is depicted as a black dot, which is responsible for the classical florid cases of cystic fibrosis, you have influences of modifier genes and environment in other phenotypes. So we were talking about the CFTR-like phenotypes, which are actually the spectrum of the CFTR mutations, which cause different phenotypes, which include asthma, bowel disease, hepatobiliary, and so on and so forth. So it is not only the genotype, there are many more things which affect the phenotype. And interestingly, this is something very new which has come up, that not only the genotype and the modifier genes and the polymorphisms, but the lung microbiome and the gut microbiome also affects the phenotype in CF patients. And it would be very interesting to do something like this in India, because our microbiomes are different as compared to the Western population, though it would be an expensive study, but then this is a very good research question which can be taken up. So the phenotype is modified by many things. So it would be important to understand the genotype and phenotype correlation in addition to the other modifiers which can have the modification of the phenotype. So coming finally to genetic counseling. So about the principles say that we have to tell the family about the disease management, and now the therapies have come up, so we have to be carefully explaining, and the cost of treatment, disease course and outcomes. So this is usually done with by the pulmonology team, which exists in our hospital and many other hospitals. We are usually contacted for mutation testing and for prenatal testing, and risk of recurrence has to be told, and prevention of prenatal diagnosis has to be explained. Prenatal diagnosis can be offered as early as 11 to 12 weeks of gestation by doing a chorionic villus biopsy. which can be done by experienced fetal medicine people, gynecologists, and the same mutation which has been identified in the affected child can be tested on. Amniocentesis can also be used. The prerequisites are you should have a confirmed diagnosis based on mutation testing. The gestational age for termination as of now is 20 weeks, though it has been now increased to 24. The implementation is still going on in India, and early referral and counseling really go a long way when you refer these families for counseling and prenatal diagnosis. There is a small procedure related risk where either you do amniocentesis or chorionic villus biopsy, but it is very small in experienced hands. Newer therapies I am not going to talk about. This is just for completion's sake. Knowing the genotype is now becoming important to know about the newer therapies as well. And it is now something like personalized medicine for cystic fibrosis. You have potentiators, you have correctors, you have read-through agents, and this will be discussed in detail in the talk which will be given tomorrow. So the conclusions are that molecular testing is important. Higher carrier frequency is probably there in India, which is shown by recent reports. Genotype is very heterogeneous in Indian population. There are no major hotspots after Delta F508. Next generation sequencing based testing may be cost effective. Counseling and prenatal testing for prevention are important. Prognosis can also be determined by genotype-phenotype correlation. We also need to know about disease modifiers and the newer therapies, but we have to be very judicious about their use because cost is very high and these drugs are new. I would like to acknowledge the team Cystic Fibrosis from the genetics group. So my mentor, Professor I.C. Verma, who actually pushed me into cystic fibrosis work and told me that you have to learn some lab work, and with that I landed up in Manchester. And this is Dr. Andrew Wallace, who actually taught me some of the molecular biology techniques in the lab. And then in our own lab, Dr. Manju Ghosh, who did the initial work, Dr. Shivaram Shastri, I referred to him earlier, Vishal, who worked on carrier frequency, Aarti, who again worked on cystic fibrosis early, and then the new team, which is now there for the new ICMR project, which is with Sushil's team, Dr. Nirja Gupta, Dr. Madhumita, and our young technologist who is Indu, and of course the clinical team, which is Sushil, which is there, which sends patients to us for workup. And acknowledgements are also there for Department of Biotechnology for funding the initial work in cystic fibrosis, AIMS intramural funding, Indian Council of Medical Research, patients and families, which have helped us in doing this work. Thank you very much.
Thank you, ma'am, for a wonderful...
For further deliberations. Thank you very much.
Thank you, ma'am, for this wonderful and very clear talk, and the past, the present, and the future, of genetics in cystic fibrosis. Indeed, it's a great eye-opener. And I'd like to introduce our next speaker, Professor Sneha Varki. And probably I'd like to say the lady behind all this today. And Dr. Sneha is a professor at CMC Vellore, Department of Pediatrics, with special interest in pediatric respiratory medicine. She's also heading the CF India project. She's the principal investigator, along with Grace's team at Columbus, Ohio. I'd like to give the time to Dr. Sneha as to tell us where are we in India in terms of diagnosis of cystic fibrosis. Over to you, Dr. Sneha.
Thank you, Aileen. I hope my slide is visible.
Yes, madam, visible.
So thank you for this opportunity. I'm going to talk about early diagnosis of cystic fibrosis in India. Are we there yet? So after the introduction, I'll be sharing some data about the age of diagnosis of CF from the published literature. And then I will discuss about the importance of early diagnosis of CF in India. This I will do in 3 parts. So before I start, I work in the Department of Pediatrics at CMC Vellore. So we cater to patients from the surrounding community, the neighboring districts, and also see a large number of referred patients from the adjacent states and the eastern and northeastern part of India. So majority of patients are from the low or middle income group of patients. I'm saying this because it has some bearing on what I'm going to present, the data I'm going to present later. All clinical cases I'll be discussing here are true cases, just that the names have been changed to protect their identity. So by now, it's very clear what the benefits of early diagnosis or newborn screening is. Dr. Grace has explained that in detail to us. But is it possible in India at a national level? Maybe not yet. Now, the new drugs, CFTR modulators, are available for clinical use in most developed countries, and it is the standard of care for patients with certain mutations. So, can we afford to leave our CF children undiagnosed or with end-stage lung disease by the time these drugs become affordable and available in India? That's the question we have to answer today. So, just sharing some data about age at diagnosis. There are many publications, but just referring to a couple of studies with large number of patients, it's between 4 to 5 years of age, and if average age, and if you take median age, if you have a large number of younger patients, it is still above 2 years of age. So we heard that the severe phenotype can have an early presentation. So we are familiar with meconium ileus. It's almost pathognomonic of CF, though certain other mutations can cause meconium ileus. Whenever there is severe or recurrent respiratory infections, we do consider cystic fibrosis as a differential diagnosis. We are familiar with that too. In this talk, I'm just going to focus a bit on this part, which is early severe malnutrition from pancreatic insufficiency. So talking about this triad, an infant with failure to thrive, presenting with anemia, low serum albumin, and edema. It is a medical emergency, and it is characteristic of cystic fibrosis presentation in an infant. Now, this is not a new entity. This has been very well described in the literature from 1970s onwards in the developed countries, as well as in our own country from South India. This particular publication is from my hospital. In 1980, 3 patients with this particular combination of hypoalbuminemia, edema, and anemia diagnosed by sweat testing, as well as after they died from postmortem studies. So the problem with this is there is a potential to confuse with other differential diagnoses, because the differential for this presentation will be inborn errors of metabolism, bone marrow failure syndromes, and many different types of immunodeficiency syndromes. So usually there is a lot of wastage of precious time and money because the investigations are planned in a certain way. For example, if you consider anemia as the important problem and you plan bone marrow examination, biopsy, etc., it will take anywhere from a few days to a week or two to get it all organized and the result available. By then, sometimes the family will give up and they will go home, or they will change the provider. So, and there may not be any continuity. So precious time is lost if we don't organize the investigations and discuss it upfront with the patient. Let me give you one example. This baby is from Eastern India. This family had 3 infant deaths, all before the age of 3 months. First baby died. Second baby developed anemia mainly. So the investigations went on with bone marrow examination, and before any conclusive diagnosis could be made, the baby died. Third baby had edema and extensive skin lesions. So they evaluated for multiple inborn errors of metabolism, and before the diagnosis, the baby died. So this family came over to our place, Velo, and stayed over for the whole pregnancy. And at the time of delivery, we were able to do a neonatal diagnosis, and cystic fibrosis was confirmed. The mutation showed homozygous for del F phenotype. Now, this is a picture of this baby around 6 months of age. You can see this is the sibling this is a child of this family who has lost 3 patients less than 3 months of age. So this baby shares the same genotype as those 3 babies, but with good care instituted right from the beginning, we were able to maintain this baby with good outcome. Now, what is our experience with early diagnosis? By early, I mean less than 2 years of age. So let's look at this group of patients. 23 patients diagnosed before the age of 2 years in the last 2.5 years, between 2018 and 2020. So 16 patients were identified from our own hospital. The others were referred either for diagnosis or for care. They were referred to our institute. So most of them were of the less than 1 year age group, with the average weighted diagnosis of 3.5 kg. And the median age of that group was 4 months. There were just a few patients above 1 year of age. Now, if you look at this distribution, you see there is a peak at around 3 to 4 months. That is when they kind of manifest. They come out, because that is the limit they can remain unrecognized. They present at around that age. And some presented a little later, but you see the weight at the average weight at the time of presentation for each of this group. It's not really going very high. Even at 1 year of age, it's not really going above, the average age is not going above 7 kilos. So once the diagnosis was made, we started multidisciplinary care involving education, personalized supervision of care. We did parent workshops for them, for the parents, visited the homes, like checked what they are doing, corrected what we could, and even sometimes supported their treatment to some extent with some help. We could say we did the best we could do. So what was the outcome of our early diagnosis? So I don't have data for all patients at all points. So at 1 month, the average weight gain from the time of starting treatment was 0.75 kg, and 3 months 1.45 kg, and 6 months about 2.35 kg. That's the average, but it could go up to 4.4 kg by within 6 months of starting treatment. Remember, these are patients who had either dropped weight or they were remaining close to their birth weight. So that is, you would call maybe a good outcome. This patient with this edema, like a kwashiorkor type with acrodermatitis enteropathica, after treatment, you see how beautiful this baby looks, and the flag sign of kwashiorkor and beautiful hair after a few months. So these kind of transformations are very encouraging for us. All of us, who we treat the cystic fibrosis patients, we are encouraged by that. Now, the question here is it, the perspective is this glass half full or is it half empty? So let's look at this data in a new way. I presented the good part, but look at this part. By 1 month, we had lost 5 babies, and by 6 months, we had lost 8. By 9 months, we had lost 34% of those 23 babies. And they all remained below 3rd centile for age, except just that one patient who we detected by neonatal period, and that baby maintained around the 50th centile. The baby is more than 2 years old and remaining at the 50th centile. So was there a lost opportunity here? All of them were born with good weight. They all noted symptoms early, a median age of 1.5 months. Actually, 8 out of the 23 families had reported an earlier infant death. There were 12 deaths in 8 families. None of the siblings had a diagnosis, though clinical features were highly suggestive in retrospect. So we asked them this question, or we kind of looked at the data to find this answer. What was the weight at the time of vaccination at 6 weeks? There were just 3 patients who had recorded normal weight at that time. Most of them, I'm including the ones where data is not available, had an average weight gain of only 0.1 kg. Some had lost weight from their birth weight by the time they came for 6-week vaccination. So is it possible for us to address this? In India, most states have a good immunization coverage. There is an assured contact with a healthcare worker at 6 weeks, 10 weeks, and maybe beyond at the least. So growth monitoring is also an established norm in India during vaccination. All we need is a surveillance to identify failure to thrive at 6 weeks and an action plan to address it. Now I go on to part 2. This is the history of baby Preeti. She came at 4 months of age. At 3 months, she had anemia. We met her at 4 months when she was, the anemia was transfused and she was referred to the hematologist then. We met her at 4 months when she was admitted in our ICU with severe LRTI. She also was failing to thrive. Now, this is a snapshot of the screen with her investigations. You will quickly recognize the problem. Hemoglobin is 6.2, albumin is 1.7 in a baby who is already failing to thrive at the age of 4 months. So you will be thinking of a diagnosis now. Those who manage such patients, you would next ask me the question, what is the pH? What's the ABG result? Yes? This is the ABG result. This is not what you were expecting. You would have expected metabolic alkalosis and some amount of hyponatremia, which is there, hypokalemia there, but you were expecting metabolic alkalosis, I'm sure. But this is metabolic acidosis. The answer for that is that this baby was having Pseudomonas septicemia and severe maybe shock at that time. So at this point, then should be considered, but this result came after the baby died because this was a very short admission. The baby was very critical when the baby was admitted. So before that, should we consider cystic fibrosis at all? Because not all features are there. There is some suspicion, but somebody with some presence of mind did 2 things before the baby died. One is to do a PR, per rectal examination, and collect a sample for stool elastase. And the other was to take a sample of blood with parents' permission for mutation testing, which much later we were able to do that testing and prove that this baby has delta F phenotate mutation. So it's a severe phenotype presenting with almost the classical triad. So is this an isolated case? So I don't think so, because I did a chart audit of the last 5 years of mortality data in our own institution. I just took the infant deaths between the ages of 1 month and 12 months only. There were 225 deaths. I believe 12 patients might have had undiagnosed CF at that time. That means 1 out of every 18 deaths between the age of 1 month and 12 months. And if I exclude the complex congenital heart disease, etc., it will fall to even 1 out of every 17 deaths. Now, you may say, how can you prove it? It is a very crude way of investigating. Yes, it is. But look at this information. In 3 of them, we had taken sample and we could prove that they had CF. And in 50%, they had evidence of pancreatic insufficiency because a stool sample was already collected for follicular elastase, though the results in some cases came much later. All of them had failure to thrive and low albumin, an average value of 1.8. Most had anemia and many had the typical symptoms of chronic diarrhea, fatty stools, metabolic alkalosis, and many had this skin eruptions. These eruptions are characteristic. They start like nappy rash, and mostly they are diagnosed as nappy rash, but they don't restrict, the rash doesn't restrict to the nappy area. It spreads to the legs, the thighs, the chest, everywhere. So that kind of a presentation, again, if you see, you need to think of cystic fibrosis. Now, can we extrapolate these numbers? Infant mortality in India is 32 per live births. 70% are neonatal deaths. So the balance happen after 1 month of age. So infant deaths post-neonatal period are attributed to main killers like pneumonia, diarrhea, maybe complicated by malnutrition. Could some of them have CF? I think they might have. Now, importance of early diagnosis in CF patients with severe phenotype. There are numerous challenges in CF management in India. For us, it is better to prevent the complications than manage them. As it is, we have enough problems managing the diagnosis. So nutritional outcome we saw is not optimal with slightly delayed diagnosis. Mortality is high when diagnosis is delayed into the first 3-4 months itself, and many are undiagnosed. So we need an action plan at national level for surveillance, using just simple clinical criteria maybe, and using investigations as a second tab. So what about less severe phenotype? I will tell you this history of two brothers, Lakshman and John. We met John first. He was 15 years last year. He came with recurrent pancreatitis. He was in shock. He had electrolyte imbalance and multi-organ failure. He was very sick in ICU. Because of the characteristic electrolyte imbalance, we suspected CF, and it was diagnosed by a high sweat chloride. He was pancreatic sufficient at that time. Those children develop pancreatitis. Those who are pancreatic insufficient will no longer develop pancreatitis. So he has a brother who is 18 years. He was reportedly asymptomatic, except that he couldn't tolerate summer season in infancy. So every summer when this child was a baby, he would get very sick. He will get admitted for IV fluids or dehydration or something. That had happened a couple of times. And then the family used to move to a relative's house in a cooler region, and the problem was solved. So the family was quite reluctant to screen this child, though we suggested we will screen. So a few months later, they came around and they came for screening. So this is the asymptomatic sibling. Yes, he had summer dehydration as an infant. He has noticed salt deposit on skin when he sweats. Reported no GI symptoms. In fact, his BMI is good at 20. Respiratory symptoms, really nothing to report, but when I asked him to cough, it was a wet cough. And this X-ray is definitely not normal. You can see retrocardiac, there are changes there. So the testing was done. He had sweat chloride, which was high, diagnostic range. His stool elastase was surprisingly low, though he had a good BMI. Then they agreed, maybe in the last few months, he was just not doing that well as before. And his CT showed early bronchiectasis, and also the pancreas was looking much smaller than you would expect at that age. These two boys were also diagnosed by mutation studies. They were compound heterozygous. One of them is a rare mutation, and the parents also we have screened. They are heterozygous for one mutation each. So is this an isolated case? So we reviewed the history of many of our already diagnosed cases, and many of them reported this type of symptoms, that they had to go to casualty, during summer, take some IV fluids, some kind of non-specific history. Many patients reported. So we did this. We did a little bit of spy work. Don't worry, I didn't do this illegally. I took the permissions and did it. So we watched the casualty, our emergency department, for patients means infants, who present in summer from March to August of 2019, who presented with any kind of suspicious symptoms like this, feeling drowsy, just one vomit and then dehydration. The dehydration is more than what you would expect with the symptoms. So by watching like that, we were able to pick up 4 cases in just that 5 months period. And one of them actually was coming to our hospital before, but was not recognized to have cystic fibrosis. I write 3+1 because 3 are under follow-up. This one patient, before we could catch them, they had got discharged, because they get very, very well, very fast. Because you give some IV fluids, saline, normal saline for dehydration, and keep them in the AC room for like half a day, they feel much better. They can leave. So they quickly got discharged. And it happens in many families with this type of phenotype, because they are very reluctant to accept there is anything wrong with the child. So we have great trouble in this group of families to get them to accept the diagnosis. So it is a milder phenotype. Many of them are pancreatic sufficient for a long time. As you see in the other case, the second child, the one who presented with pancreatitis, is pancreatic sufficient now, but he would probably become insufficient down the line. That is what must have happened to the older brother. He would have been pancreatic sufficient initially. That explains his good growth in the beginning, and now he's become insufficient. And if left alone, they will follow the same natural history and progression. And instead of presenting with bronchiectasis in the first decade, they will present with bronchiectasis in the second or third decade to adult physicians who really don't think much about cystic fibrosis. So the diagnosis may even get missed. So in conclusion, I just want to look at what could be the numbers we are looking at. So we listened to Grace, who's working in this place, Columbus in Ohio. And her center is one of the 5 centers. And we have kind of comparable area, size of the state. Total population, we are almost 6 times higher than, Tamil Nadu is 6 times higher than Ohio. So she mentioned they had about 10 or 11 patients in 1 year, that is in 2018. So that may be average of 10 to 15 patients per year in this one center. So 5 centers will see about 50 or 75 patients. And my numbers are that in infancy, it is not by newborn screening, but we are seeing infants about 8 to 10 for a year. So we are not one center. Probably there are 8 to 9 or 10 centers in Tamil Nadu of handling equal volume, patients of similar background and complexities. So between all of us, we may probably be seeing equal number of patients as they are seeing. So in conclusion, I would say delaying diagnosis beyond 2 months results in very poor outcome in severe phenotype. There may be significant mortality due to CF in India. The patients may be dying undiagnosed. And early diagnosis is important to prevent or at least delay organ damage in mild phenotype. And in spite of many challenges and limitations we have, we can do a lot in India if we put our mind to it, because we have eradicated polio and we are managing COVID to an extent which we didn't really imagine before. At least the cooperation of many groups together. So we need to educate to raise awareness among doctors and even public. I would suggest that cystic fibrosis is a compulsory case for MD pediatric examination, either as a long case or at least as an OSCE. Public awareness is important because unless everybody knows, we are not successful in treating. Because if you say cancer or COVID-19, neighbors, friends, relatives, everybody will say, please go to hospital. But if you say cystic fibrosis, they will say nothing like that. We never heard such a thing. Don't go, your child looks well. Or if the child is very sick, they will say, you have been going to the same doctor for some time now, it's not getting better, so change the doctor. So, we need public awareness about what cystic fibrosis is. Not last but not the least, I must acknowledge IAP National Respiratory Chapter, Dr. Jagdish Chinnappa and Dr. Subramania for doing this particular Respinar and for their support. I acknowledge the contributions of my colleagues in my department of pediatrics for their teamwork and their dedication in managing all the patients. And CF India project, which we are doing with the Children's Hospital at Columbus, supported by CFF USA, which has provided me the luxury of having this team, which consists of, Madan, who is also interested in pulmonary, Lynette is interested in gastroenterology, Hari and Jivita are respiratory therapists, Dina and Esther are nurses. We have Shinsi dietitian and our coordinator Lavanya, and Mr. Tondeman comes with us for sweat testing camps in different places. We have done only 2 so far. We were hoping to do many more to help people across India to diagnose this. Hopefully we will resume this after this pandemic. My thanks to families from whom we have learned a lot, and to many other pediatricians, especially Dr. Kabra and others who have worked tirelessly to improve the standard of CF care in India. Thank you very much.
Thank you, Dr. Sneha, for such an excellent, wonderful presentation. Indeed, an eye-opener. Perhaps we are at the tip of the iceberg, not really. We need to heighten our awareness. We'll go on now to the next talk, and this is regarding the CF registry. I'd like to introduce Professor Gary Cornett. Again, all of us are familiar with him. He needs no introduction, but Professor Gary is a pediatric respiratory consultant in Southampton since 1995. He has collaborated, as Dr. Kabra has mentioned, with the team at AIMS since 1999. Since 2018, he is the professor at the University of Southampton, and he leads the provision of CF care services for children. He also is the head of School of Pediatrics in the south of England, and he has created this Pediatric Innovation, Education and Research, the PIA network, and he made significant contributions. In 2017, he has been awarded the prestigious Ensomo Oration at Respinar 2017. He has also, this has also inspired him to take forward an initiative to help develop an Indian cystic fibrosis registry, and which he will be enlightening us in his talk today. Over to you, Gary. Thank you.
Thank you, Eileen, for that kind introduction. I hope you can hear me speaking and you can see my slides.
Yes, sir.
Good, excellent, great.
Yes.
So, good evening, everybody, and it's a great pleasure to have this chance to see and meet up with friends and colleagues across India. Just a shame that we can't actually be physically together because of the current pandemic that we're all dealing with in our own hospitals. But it's still a pleasure to be here, and it's great to see over 200 people across India interested in cystic fibrosis, and rightly so, because as Sneha has been telling us, there's a huge amount more to learn and discover about what's going on with cystic fibrosis across India, and it's very tantalizing and I think very exciting. So the reason why Sneha has asked me to talk on experiences from CF Registry in the UK is because last year, Professor Kabra and I put in an application to get an innovation award to repurpose the UK's CF registry for use in India. And we were successful in that, and we were very excited to think about how we might start to collect some objective data about cystic fibrosis in India going forward. Unfortunately, the COVID-19 pandemic has put that on hold to a certain extent, but hopefully this meeting today will help energize us all, get the research up and running again, and we can think about taking this project forward with all the new cases that I hope we're going to diagnose now that you've been made aware of the condition through the excellent talks you've been hearing earlier on today. So, let's see if I can. Yeah. So the first thing to say about this talk is that I'm going to show you a lot of slides actually from the Cystic Fibrosis Trust, our UK charity, who hosts the UK registry. They've been collecting data over many years, and that's been extremely useful and powerful for us as respiratory paediatricians in being able to capture objective data about the disease to secure funding and resources, organisations and services to go forward. And Rebecca Cosgriff in particular has been really helpful in this project over recent years, and is working with us with the India project to try to help get a registry up and running effectively across India. Here's some headline data about cystic fibrosis in the UK. Currently, there are around 10,500 cystic fibrosis patients on the books, and we provide input about those patients around an annual review assessment of these patients. One of the aspects of care we have in the UK is, as well as seeing our patients regularly, usually every 2 months, perhaps 3 months in adult services, we do an annual assessment where we do more detailed assessments of lung function, we do chest x-rays, we do blood tests, screening for metabolic complications. And that data is the backbone to the annual review stuff that's put into the registry to capture what's going on with the CF population. You can see the vast majority of our patients are in England, but there are patients in the other less populated parts of the UK around the edges. Our median age currently is about 20 years of age, and currently around 27% of our patients were diagnosed by newborn screening, something we've been doing now for about 12, 13 years across the UK. So more and more of our patients are coming to us via that route. When we first started collecting data, around about 20 years ago now, it was done with paper records. We were writing things down and sending off forms to a central place where that was then entered into computers. But as time's gone on, and with training and support, we are now using electronic registries. We have a host server where the database is kept, and we can all access that and enter our own data as we do the annual reviews to capture the up-to-date information about our patients going forward. And we're now doing some very exciting things with the registry. We are running currently a randomized controlled trial. One of the quirky things we do in the UK is we give flucloxacillin to our babies for the first few years of life to try to get rid of Staphylococcus aureus as far as we can do. But we're not convinced that's a good idea. So what we're doing currently is actually running a randomized controlled trial whereby those patients who are on the registry can either be randomized to opt into receiving flucloxacillin or not. And we then use the registry to collect and capture follow-up data to answer the question, is flucloxacillin a good idea or not? So that's just one way in which now we're doing actual clinical trials and studies through the registry as a UK collaboration across all of the CF centres working together to answer important questions about what's the right thing to do for our patients. So here's a little diagram taking you down the pathway that gets data collected and used. First of all, we need consent to collect patient data. We need national consent from ethics committees and approvals. And I believe Professor Cabra has been taking that forward for us in the background and getting those approvals in place so we can do similar across India. The data entry is done manually in our country now by people within our CF clinical teams. I'll show you some of those people in a minute. But initially, we actually had to have help from the actual registry team, the CF Trust, going out to us, meeting with us, showing us how to use the systems and encouraging and supporting us to ensure that we were entering good quality data. If it's rubbish in, it's going to be rubbish out. And the importance is there about honestly reporting our outcomes objectively so that we can actually then move forward scientifically to try to improve standards of care. The registry team look at the data and they validate entries. There's an element of data cleaning. If there are measurements which seem extraordinarily out of proportion to what might be expected, they can raise queries and they can clean the data to ensure that what's being entered is not in error and clearly incorrect. And that data can then be used to produce reports. We have an annual registry report, and I'll show you some data that we get as outputs from that. We can benchmark ourselves, and that data can be used also in many other ways, which I'll talk about. This is a nice slide showing lots of people across the UK. You might see, if you look closely in each of those pictures, there's one person who's a recurring theme. That's the lady in glasses called Elaine Gunn. And she's been one of the people who's been key in the CF Trust to getting our registry up and running. And you can see she's gone out and visited all of the UK centres to meet with the local teams, work with them, encourage, answer their queries, ensure the data quality is good and improve things. You might see down there at the bottom, there, second in on the bottom from the left, there's a lady there in the middle. That's Nikki, my secretary, who does a lot of the data entry. And she's supported by Suzanne on the left in the glasses in entering our own data. So we delegate this to well-trained clerical staff to get this right. And they have been educated and supported through the CF Trust by people like Elaine to ensure that this is done properly. You can see here on this slide some numbers about cystic fibrosis across to Europe. And you can see that the UK is the winner in terms of numbers of patients by a significant extent. It's a disease that's more common in the northwest of Europe in particular. And we now have means whereby we can get the registry from other European countries, the data there, to talk to each other. And we can benchmark ourselves against other European countries, as well as within ourselves, between our centres in the UK, to see how we are doing. And that's a very nice collaborative effort that brings people together. And again, we would hope that with the UK registry being repurposed for use in India, we might then be able to do similar benchmarking and cross-talking across other countries globally. So here's some data. Let's not worry too much about the numbers in detail, but it's just showing you some longitudinal data about some cystic fibrosis outcomes over the last 6 years, up to 2018. You can see a slight increase in the median age of the population, reflecting improved outcomes from a median age of 18 to 20 there. A high rate of entry of annual review data in over 90% of patients to get some sort of registry outcomes. And it's interesting just to look at those numbers there for the newborn screening and the number of patients that we're identifying in the UK. So we get 150 kids there a year in 2018. And even if Delta F508 was the only gene mutation that you could test for in India, and the figures were as low as 1 in 40,000, although I think Sneha's convinced me it's much, much higher than that, you would still be getting 650 patients a year, according to Professor Cabra, who I'm sure is right, and that's 4 times the number that we're getting through newborn screening in the UK. And that's, that is the most conservative estimate that you can come up with, I think, for cystic fibrosis in India. And it's almost certainly many, many times higher than that. We managed to diagnose the majority of our patients in early infancy, and that importance of early detection and treatment cannot be stressed enough. We heard talk about the benefits of newborn screening there, and it's really, really very, very important, I think. We have a increased survival amongst males versus females. That's an interesting observation. Most diseases, girls do better than boys. In cystic fibrosis, there's a survival advantage there for the male sex. This slide I thought was interesting to show you. This is just looking at some of the symptoms that come up in those patients who are not identified through newborn screening. And whilst we get that classic triad of the fatty stools, the failure to thrive, and the respiratory infection, in the UK now, 40% of our patients are presenting with other presentations. And again, Sneha talked about there the pseudo-Bartter syndrome, the hypoproteinemia and anemia and ascites. And I'm sure those are presentations which are very common in India. A little anecdote for you. We had a link with colleagues in Tirana in Albania. And in Albania, we saw very early on that many of their cystic fibrosis patients were presenting exactly as you've just heard, with the anemia and the low albumin levels. And so they ran a campaign to make their pediatricians aware of what they called cystic fibrosis facies. And the cystic fibrosis facie was the anemic, puffy child. And through that campaign and awareness, they increased their diagnosis of patients. And in fact, in Albania, from what I've heard most recently, 1/3 of their cystic fibrosis population were diagnosed with that presentation. So it clearly varies around the world. It's probably a micronutrient deficiency, in the same way as the neuropathy might be related to vitamin E deficiency. And that awareness led to a huge increase in diagnosis and recognition in Albania. And I suspect from what I'm hearing today, there's a very similar story to be told about cystic fibrosis in India. Here's our age sex distribution. And what's been happening over successive years is that it's becoming more of a flat line with improved survival into adult life, into later years for patients. Here's a slide which continues to point out the challenges that we still face. This is lung function for those who can produce spirometry. The data is shown here against age, and you can see that despite our best efforts, lung function still declines quite steeply in later childhood, in the teenage years, and then plateaus amongst the survivors in adult populations going thereafter. And I think that the key thing probably going on here, as well as the progression of the disease, is the challenges we have with adherence to treatment. And that's one of our biggest ongoing unmet needs in the UK, getting our patients to remain engaged and maintain high levels of adherence to what it is we demand them to do to try and stay healthy. That's a real big problem that we still face and are trying to solve. This is a slide I never tire of showing. It's one that's very similar to what Professor Cabra showed us earlier today when he talked about the improved survival related to nutrition. This is adult data taken from the CF database. The same is true of pediatrics. And you can see quite clearly the relationship between a low BMI, poor indices of nutrition, and low lung function. And people may argue the chicken and egg problem here. Is it the bad lung function causing poor nutrition? Is it poor nutrition causing bad lung function? It's probably both in a vicious circle. But what's true is that if you can intervene to improve the nutrition of patients who are doing poorly, it stabilizes and can improve their lung function. So when I have my back to the wall with a patient who I'm struggling with, back to basics is to get nutrition right first, and then everything else gets much, much easier. A really important lesson that we cannot tire of stressing over and over again. Here's our UK genotype data, and you can see that in the UK, by far and away, Delta F508 is really common. And in fact, 90% of our patients have at least one copy of the 508 mutation. And it'd be lovely in a few years' time to see a similar kind of a picture of the Indian subcontinent and arrows showing the genotype distribution across India in the same kind of way. That gives us an idea about what kind of genotypes that we have and what the implications there might then be for treatments in the future when we get CFTR modulators on board as part of the standard of care. This is an interesting slide I thought I'd share with you. It's showing you listed there all the different pediatric CF centres. So each number represents a CF service across the UK, and the percentage graph is showing you the amount of DNAs, the pulmozyme, the enzyme treatment to try to thin secretions, and hypertonic saline, a medication to hydrate secretions to increase the clearance of the airway with physiotherapy. And the thing that I think is quite striking is the variation in practice. You know, we have guidelines, we have standards of care. When you look at what's going on in detail in centres, there is a huge variation in practice between the different centres across the UK. And that's worth knowing about because it is important for centres to see this data, to reflect upon what they're doing and think about whether or not they need to change practice to become more in line with other centres and whether this may have important implications for their own outcomes. We used to show outcome data in this way on our database. Again, we've got all the CF centres here with box plots of their median lung function and the interquartile range around that. But nowadays we present the data like this. And this is a funnel plot. And I think this is really very useful. So in the interest of openness, Southampton is number 29, which you might be able to see there towards the, thankfully above the median. And we are about the 6th largest centre in terms of numbers of patients for paediatrics in the UK. And we're plotting here the median lung function, the mean lung function, sorry, as a percent predicted, against the clinic size. And just out of interest there, you can see number 75, which is sitting more than 2 standard deviations outside of the median lung function, the mean lung function for our country. And just going back there to the treatment, number 75, you can see we're really using a lot less DNAs and hypertonic saline compared to many other centres. So maybe there's some learning here that can come out of this for centres by having this kind of data, seeing where we're at, and thinking about how we can do better when we look at the treatments as well as the outcomes that we're able to provide for our patients. There may not be easy solutions, but identifying the problems is step 1 to trying to solve them. And here's the same data again showing you outcomes for nutrition with BMI percentile as we use in pediatrics to see how we're doing compared to other places. The registry data can provide all sorts of other interesting and useful and powerful information to take forward. We can link our postcodes to health inequality outcomes. and we capture the postcode data, and that's been quite useful and powerful in terms of trying to recognize how inequalities are important. And I'm sure the same will be true in India, to try to think about how we can address health inequalities and move forward with funding and support to meet the care needs of those who are disadvantaged. Health economic data, we can use our data to capture and predict the costs of care on the basis of the standards we hope to achieve and campaign to achieve that. Longitudinal data can give us ideas about survival for our patient cohorts. And we can look at the treatment effects in the way I've just shown you, as well as linking our data to outcomes in relation to other things that we're doing to support our families. And then most recently, we've been working with industry. And I think once you start getting good data, the drug companies come sniffing around and look at how they can also benefit from looking at data and going forward. And we actually now get funding into the registry from drug companies who are looking at post-marketing surveillance of their drugs to see how well their drugs are working and get safety data in a relatively cheap and effective way through capturing the outcomes, the reported registry annual review data about our patients in relation to their drugs. So that's something else that may well be there for the future if we can get a registry running effectively across India. And finally, I just thought I'd share with you some COVID data, a little bit out of date now. We've now got 31 patients, I think, last week on the UK registry, but we're now using our registry as a go-to place to report COVID-19 whenever it's been diagnosed in our cystic fibrosis patients. And we can then input data about various outcomes in relation to COVID-19 to get a clearer idea about how this disease is affecting our patients, which we can then feedback and provide information and advice nationally and personally to the people under our care. So finally, just to mention, having a registry has, I'm sure, been quite useful in the arguments we've been able to make to get access to drugs, and in particular those CFTR modulators, those game-changing drugs which pharma have now produced, which are correcting the CFTR defect, normalizing sweat tests, and literally having life-transforming benefits to our patients, those who have the Delta F508 mutation. And we've just in the UK, I'm not sure if you're aware, in the last couple of months have secured NHS access to these drugs for our patients, which is just amazing in my opinion, and makes me extremely happy to think that we can now do that. And part of getting to that point was having our registry to know exactly how many patients there were, who had what it would cost, and how we're going to afford it. You know, that was the data that got us to where we are now. So that is, you know, the future, and that will come to India. You know, that you are going to have at some point these drugs, and they will be amazing, and we need to get ourselves in order to identify the patients who will get them. So there we go. That's my last slide. It's the front cover of the 2018, the most recently available registry report. And wouldn't it be nice in a few years' time to have the India Cystic Fibrosis Registry annual data report in 2000, and I'm not quite sure when, I don't want to call it, but hopefully in the not too distant future. So there you go. That's the end of my talk, and thank you very much for listening.
Thank you very much, Gary, for that excellent talk, and indeed very encouraging for us to hear what your team is doing, and also for our country. We still have a long way to go, but I think we're all very positive. I'd like to introduce our next speaker, Dr. Jagdish Goyal, and he'll be speaking on the CF registry in India. He's working closely with Dr. Kabra and team on this project. Dr. Jagdish is an additional professor in pediatrics at AIIMS Jodhpur with special interest in pediatric pulmonology. He's also published various research papers, and also was a visiting fellow in pediatric pulmonology in 2017. Over to you, Jagdish.
Okay. Thank you, Dr. Aline. Thank you for kind introduction. At the outset, I am thankful to IAP Respiratory Chapter for inviting me for this talk, particularly Dr. Sneha Virki. So in next 10 minutes, I will be discussing about development of CF registry in India. Where are we? So outline of my presentation will be what is patient registry, estimate of CF burden in India, need for CF registry in India, challenges in development of registry, what are the recommended minimum standard, and current status of CF registry in India. So what is patient registry? As you all know, that patient registry is an organized system that uses observational method to collect uniform data to evaluate specified outcome for a population defined by a particular disease, condition or exposure, and that serve one or more predetermined scientific, clinical or policy purpose. So coming to cystic fibrosis, burden of cystic fibrosis, this has already been told by Dr. Kabra that CF is not uncommon, and if we'll go by statistics, in Indian migrants it was 1 is to 40,000, and Indian who have been migrated to UK, it was 1 in 10,000. So this was the slide taken from Dr. Kabra. So you can estimate the CF cases per annum accordingly. And majority of patients are not diagnosed, and even they don't get proper treatment. So why we need CF registry in India? As Gary had rightly pointed out, we need to improve identification of children with CF. Still, as Dr. Kabra told in his talk, that still most of the children are not identified. And we need to build capacity. So capacity building of center across India for CF services. And we need to develop India-specific treatment protocol. Since we know that the climatic condition and other conditions are very different from Western world, so we need India-specific treatment, and some of the treatment might not be affordable for our patient. So we need to think about innovative ways of treating CF patients. And we need to estimate prevalence of cystic fibrosis in India, because still we don't know the exact prevalence. And we need to document common mutation of cystic fibrosis in India. And also we need CF registry for research and development. Now, what are the challenges in development of CF registry? It requires extensive time, manpower, and financial implication is always there. So huge financial investment is required to maintain the registry and to sustain the registry. There should be uniform standard to collect and organize the data. As Dr. Gary rightly told, if you put rubbish, you will get out rubbish thing. So we need standard uniform data and robust data to enter in the registry. Then completeness and quality of data. Then data validation. So there should be data validation at each and every steps. And again, financial implication to maintain the registry. Once we have started the registry, for maintaining long-term registry, again, there will be a lot of financial implication. Now, these are the minimum recommended standard for registry. There should be development of a formal study protocol. There should be plan for data analysis, as Gary showed regarding flu, cloxacillin data. So we need, if we give one, suppose we introduce one intervention, what is the effect on the patient of CF? So this we need to analyze on our data. Then we need to define clinically meaningful outcomes. Then we need to linkage with other registry, like India, we can collaborate with UK, and then we can see how our patient do and how we can learn from UK patients, and then follow up based on registry. Then provision of patient privacy should be there. And again, we should need to ensure the data quality. So coming to the current status of CF registry in India, there is one project which is going on, and it is funded by Indian Council of Medical Research, and the objective of this project is to improve diagnosis and management of cystic fibrosis and capacity building of medical college hospital across India and develop registry. And principal investigator is Professor S.K. Kabra, and there are other 3 sites: CMC Vellore, AIIMS Jodhpur is my site, and SKIMS Srinagar. So these are other 3 sites which are involved in this project. And primary objective is to develop CF registry by improving identification of children with inexpensive aquagenic wrinkling, as shown by Dr. Kabra, as a screening tool on children with phenotype, and confirming diagnosis by using indigenously developed sweat chloride estimation. Then capacity building of centers across India for CF services. Then we need develop India-specific treatment protocol. So these are the primary objective, and secondary objective of this project is to estimate prevalence of cystic fibrosis in India and to document common mutation of cystic fibrosis in India. So initially when patient comes to us, if there are 2 out of 3 symptoms, this is form A, this is screening form. We need to fill this screening form if child is having failure to thrive, recurrent or persistent pneumonia, or frequent bulky stool or oily stool. If 2 out of 3 symptoms are present, then child is screen positive, and then we fill screening form. Then there is form B, in which we fill all the demographic details and we do sweat estimation. And if child is turned out to be, means his or her sweat chloride is positive, means then we need to fill form C. And then there are form D and E for follow-up. So we fill all the details regarding demographic, lab investigation, lung functions, cultures. Each and every detail is filled in this form, and we also do the CF scoring of the patient, and then finally this data is entered in this site. So this is online data entry site in which we used to enter our data. I think this site is visible, online site. Okay, so this is the site, online site, in which we used to enter the data. And suppose I am entering the data from AIIMS Jodhpur. So username and password is given, and once I will log in, then I will go to the data entry form, and there are data entry, and there are various forms, like this is form A, and you can see we can save as draft, and once we complete the form, then we save it at final, and then this data is verified by AIIMS Delhi, and they will finally be entered in CF registry. So till now, 94 patients have been registered in entry, 57 from AIIMS Delhi, 16 from SKIMS, 10 from my side, and 11 patients from CMC Vellore. And these are the mutation profile. You can see the delta 508 mutation, homozygous mutation was present in 8 patients, heterozygous mutation was in 8 patients. Then we are doing 2 common mutations as told by Madhulika ma'am, intron 19 and delta 508. And then you can see the compound heterozygous intron and delta 508 was present in 4 patients, and 1 mutation was identified in 11 patients. So total, we were able to identify 37 mutation, mutation in 37 patients out of 62 patients, and rest patient will be sent for NGS. So to conclude, CF registry in India may be appropriate tool to understand clinical characteristic of our patient, and it will also help in research and development. We need to explore funding opportunity, and there is a great news that Gary has one project. So I think with this funding opportunity, we might be able to maintain and sustain registry, and CF registry may also help to improve the long-term outcome of our CF patient. I would like to acknowledge Professor S.K. Kabra, who is my teacher and my mentor and who taught me ABCD of CF care. And I would also like to acknowledge my colleague, Dr. Praveen, who along with me is associated in CF care, and I also learned a lot of things from him. Thank you for your kind attention. Thank you.
Thank you very much, Dr. Jagdish. That was an excellent presentation. And indeed, it's very heartening to see there are so many, the project that is ongoing. And we do hope that we will see more registries and more studies available for our patients, so that, in time, our patients benefit from these studies and also for the future care. I think with the paucity of time, there were a lot of questions. I think there were about 25 questions that are already answered by the panelists. Really appreciate your answers and thank you so much. Dr. Kabra has had to leave because he had another ongoing webinar. There are a few questions. I think Grace is with us tomorrow as well. So there are some questions that Grace can take tomorrow. I request if Dr. Madhulika can answer some of our questions here.
Yes, sure. I have tried to answer almost all which were directed to me. But if there are any which are left, I would be happy to answer. No issues. Let me know if there are any questions related to genetics. I would be happy to answer. Or there is any confusion in the answers which I have written, I can answer them live.
Yeah. So, is there any other questions that I think ma'am has brilliantly answered? There were 2 questions on exome sequencing, the clinical exomic sequencing, if that has already been answered. If there are any other questions for ma'am?
Eileen, if I can come in for a while.
Yes, sure.
Just a minute.
This is from this thing. Suppose if any of the persons or delegates or attending would like to come in, raise your hands, and then you would like to come in and ask the question, also you are welcome, because this would be a small group, but we cannot allow too many, maybe 1 or 2. If that is there, we would request the ClearNet people to allow them to come in and then for a while and then go back. If there is let's get the things clarified, then let them not move on with the session. Anybody, if you want, you please raise your hands in the options that have been given. Archana, could you help them if required?
While we are waiting for that, I think all the sessions are brilliant. I would like to just ask Dr. Jagdish Goel, and since Dr. Kabra is not here, what is the ultimate goal of the registry? Is it to include all centers in India, or at least expand this to all centers in India, or is it going to be restricted to just a few centers?
Okay. Thank you, sir, for your question. This registry currently we are going on for only for 4 centers, AIIMS Delhi and 3 other centers. But I discussed Kabra sir also. So in future, we are planning to include more centers. Right now it is restricted to 4 centers, but definitely in future we are planning to register more centers. But again, as Gary has rightly told, there are issues with data quality. So we need to ensure that once we open the registry, then there should be adequate data quality. So this is a issue. So I discussed with Kavra sir also. So in future, hopefully we'll be able to open for all patients or all other centers.
Thank you, sir. Thank you very much.
There is a question for me by Dr. Venkatesh. We
Yes.
see mutation positivity
ma'am.
in children with only high sweat levels, more than 90 or so. Why is that so? So Dr. Venkatesh, this is not correct that we would see mutation positivity in more than 90. 60 is the cutoff for the sweat chloride, which is usually taken, and you will get mutations. In fact, if the sweat chloride is borderline and the phenotype is quite suggestive, you may get mutations also. So the relationship of the curve which I showed to the sweat levels, it may be related to the severity of mutations and the association of the modifier genes and polymorphisms which might affect. But it is not that you would see mutations only in patients where the sweat chloride is very high. You can see it in patients with more than 60 with a suggestive phenotype, and even in borderline cases where you may have mutation negativity. And as I said, some of the patients have normal sweat chloride in cystic fibrosis, and there also you will be able to find the mutations.
Can I ask a question?
Thank you, ma'am.
If you permit me, Dr. Gary, Madhulika Madam, Dr. Sneha Varki, Eileen, Dr. Jagdish Prasad Goyal, and everyone. What we from the respiratory chapter would wish is that this is a very nice Respinar with the deliberations from each one of you as experts in the field. Let me put myself in the shoes of a common pediatrician. He needs to have a modular training with 15 to 20 minute sessions on what is CF, how to diagnose CF, how to how to do investigations, some videos. We have been doing workshops, I agree. But there has to be some kind of a module, a teaching module, which can run across the country. And as with the permission of President Dr. Jagdish Chenappa and myself as secretary, we will see that the module runs across the country and there are more number of participants. We do understand the kind of the data you are presenting. We do understand the statistical importance of it. But what it is important for a common pediatrician from his perspective would be, am I seeing or am I not seeing? If so, is it CF in disguise or what? Therefore, there has to be a sensitization module, which I would request Dr. Gary to, with the Cabra sir and everyone, to bring it forward at the end of the complete 2 days session, but later work on a module. It could be just 3 or 4 hours module, but I will assure you from the chapter that this module will run at least 10 to 15 times across all the zones in India. So this is a small, humble submission, but we will see that the dissemination is done from our end. But we want a robust module that a common pediatrician and a general pediatrician can understand apart from pulmonologists.
Can I answer this question?
Go for it.
Yeah. Actually, sir, already in this project, we are having capacity building program. So we are already having module. Dr. Cabra has devised this module, and even our center has conducted 2 such type of workshops, one at Bikaner and one at Kota. And we have trained 30 pediatricians, 35 pediatricians in each session. So we are already doing this.
No, but my point is that let it get branded from IAP respiratory chapter activity, and it will get a much more broader representation than from an institution. Jagdish, you are also part of us as EB member. So why don't you take the lead in the chapter and take it forward to reach out to everyone. So the chapter will have a more reach out than an institution. I'm not telling in any other sense, but to see that every pediatrician will get his cake.
I think that's an excellent idea. And the one thing that strikes me about India is just how big it is. And there is room for everybody to take forward projects, initiatives, and ideas about promoting and increasing the awareness about cystic fibrosis. And you cannot do too much of this kind of thing. So yeah, I think you're absolutely right, and I'd be more than happy to help collaborate, drawing on the experience from the peer education projects we've been doing, to try to get the right kind of materials for you. And I think Sneha made a very good point about, we need to think about maybe the medical schools and the curriculum and what's on there, and if you can bring leverage to ensure that whatever the textbooks have said is no longer relevant to today, and the modern medicine is about a different perspective on cystic fibrosis in India for the undergraduates, as well as what you can do for your postgraduate training as well. I think they're both equally important.
Thank you. Eileen, please come. Unmute yourself.
Thank you, Gary. Thank you, Gary. There's a question from, Dr. Gautam. Sorry, I think somebody has answered that. Gary, what is your experience, or rather, what is the prevalence of CF in the Asian population in UK? And is it different from the Caucasian?
I'm not up to speed with that answer specifically, but I think a lot of the Indian population in the UK are from the northwest, and we've seen from Professor Cabra's data that I think a lot of the patients that have been diagnosed in AIMS have come from that part of India. So I think we get quite a high incidence of cystic fibrosis. We have a lot of first cousin marriages among closed communities in the UK from that part of India. And so the incidence is relatively high. I can't put a precise figure on it, but it's not that different from what we see amongst the white Caucasian population from Northwest Europe. But I think I just qualify that by saying that is from a rather limited area of India that tends to come to the UK in larger numbers. I think Madhu might have some comments on that. Is that Madhulika? You're seeing a lot of that, your own patients from the Northwest as well, aren't you? I think. I'm not sure she can hear.
Dr. Madhulika, I think ma'am can't hear. Is it not audible?
Am I audible? My mic is on.
Yes, ma'am. Yeah, you are.
Tell me,
ma'am, your experience on this. Yes.
So as Gary just said, initially most of our catering area is north, right? And then when we get patients from Delhi, Punjab, Srinagar and so on, so there, because of the population migration, we would expect that there would be more of delta F508 there. And in UK, the Indian and Pakistani population which is there, maybe the population which is migrated from north may have more of delta F508. And the data which is available from the migrant population in UK and US is on limited population. But then I'm sure that if you collectively do mutation testing on Indian population residing in UK or the US, you will have a similar mutation pattern which we have found. So you will not be finding very many patients of Indian origin. Maybe Pakistan may have more of delta F508, and there are some more mutations which are more commonly seen in Pakistan. So that may be a difference, but then I think the mutation profile is going to be the same if you have patients of Indian origin tested in the UK or the US.
Okay. Thank you very much, ma'am. I think we'll take the last question again to Dr. Madhulika. Ma'am, there's a question from Dr. Gauri Shankar. He wants to know whether the Sanger sequence versus the NGS, is there a preference? Is there a reason why, or you would choose one over the other?
Okay, so as I said, Sanger sequencing is the gold standard for mutation testing. Okay, so whatever you do using NGS, suppose you are doing a clinical exome, and just to clarify, clinical exome has selected genes, whole exome has all the known genes, and whole genome has even the intronic region. So theoretically speaking, you would pick up all abnormalities, almost all on whole genome sequencing. So Sanger sequencing is the ultimately gold standard for any sequencing data. But what happens is it is more time consuming because you have to sequence exon by exon, and it takes longer time. And in the present time, it is turning out to be more expensive for big genes like cystic fibrosis. On the other hand, if you are using NGS based technology, there you have massively parallel sequencing, where you have parallel sequencing of multiple exons, right? And you identify it. But the recommendation as of now is, even if you identify a variation, pathogenic variation on whole exome sequencing or clinical exome sequencing, it has to be confirmed by Sanger sequencing. So nowadays, for big genes, or if you are testing multiple genes altogether, all the known genes, then NGS based testing is preferred. But if you have in 80% of population, if you have one single mutation, then obviously you would prefer to do either direct sequencing for that particular exon or use a PCR based technique for testing for that mutation. Obviously, you will not do a clinical exome for CF in the UK or the US, because you know delta F508 is there in 75 to 80% of patients.
Thank you, ma'am. So I think we can. In the interest of time, I think I'm going to ask Dr. Subramania to close in, as it's already almost way beyond the time that was planned. Over to you, sir. Thank you.
Thank you, Eileen, for being so generous and for conducting the session today. First of all, let me personally congratulate you for moderating this session from all of us. Secondly, Dr. Gary sir and Dr. Grace, it's not easy, but when you travel, you will have jet lag, but hopefully now you are comfortable. I do not know the timings there. I wish that it's fine. It looks sunny at both the places, and therefore we would sincerely thank you for being with us. I don't know, I'm little emotional, the kind of pains that you take, the smile that you have always for the questions would fill us with lot of energy to serve these kind of patients, and the kind of persistence that you have over decades. I think not just complimenting your talks, hats off to you from Indian Academy of Pediatrics Respiratory Chapter. And more than you, our own couple who have been doing great lot of services for these patients, Madhulika Madam and Dr. Kabra sir in absentia. I think if I allow the chat box, will you all congratulate Madam and Sir? I request all those participants, please type and congratulate both the couple. I want all the messages in the chat box, please. Please type. Congratulating both of them for decades of service, and you have produced such kind of students like Jagdish Prasad Goyal, who is my EB member in the respiratory chapter right now, and he is taking it forward. To see your own student as one of the co-faculty is something which is fulfilling for any teacher like you and Kabra. And Dr. Jagdish, you have kept the respiratory chapter spirits very high, and we are very proud that you are also our executive committee member. Not only that, he has been a critical reviewer of many of our projects. Gary sir, let me share with you that this youngster who has joined us is one who is into many modules of the respiratory chapter now. So we have a wonderful team from Indian Academy of Pediatrics Respiratory Chapter that is taking it forward. Tomorrow join at the same time, and we will continue the session on cystic fibrosis. But before you log off, let me also tell you that day after tomorrow at 4:30 p.m. in Indian time, we have a wonderful session on cough module, cough in children by Professor Annie Chang, the world #1 authority on cough. So we can hear live from her. Sir, to all the invitees from abroad, let me share with you that we have wonderful faculties participating in Respinars, which is keeping the interest of respirology high amongst Indians. So over to Dr. Jagdish Chinappa for final comments and for closing the session.
Thank you, Dr. Subramania. And I think he has already voiced much of what I was going to say. And I think we must particularly thank Dr. Sneha Varki for getting the family together. And I think we should see that we take this message to all the pediatricians to at least recognize CF early, so that we can at least do something for these children. We may not be able to give the avocaftors and the lumicaftors, but at least we can take care of them in a decent way for as long as they are functional. So with this, I thank all of you again, Dr. Grace Paul, Dr. Madhulika Kabra, Dr. Kabra. Dr. Gary Connet has counseled one of my CF patients for almost 2.5 hours, and I still have his recording. So I know what his commitment is like. Dr. Jagdish Goyal, thank you very much. And of course, Dr. Eileen, my colleague, who has snatched away all my CF patients after coming to Manipal. I'm very grateful because she's doing a more professional job than what I do. So thank you all for that wonderful session, and hope to see you tomorrow. Thank you.
Thank you very much. Thank you. Bye. Bye, Grace.
Bye.
Thank you, Sneha. Thank you, everyone. Thank you very much.
Yeah, madam, I thought I will thank you tomorrow at the end for the entire session. So, so I had kept that all my emotions for you reserved. Okay. Okay. Nice seeing you. Okay, madam. Bye. Hello.